All right, Jen, I will let you take the reins. Do you have, can you share your screen, or do you have anything you need to share or send me that I can share for you?
I don't, what I'm really going to do is really talk about those PowerPoints that we had at the meeting.
Do you want me to pull the PowerPoints?
Yes, it's the same one from the tech meeting, but it's pages 11, 12, and 13. And the rest of the stuff is the ESI stuff, which we could just talk freely about.
All right, give me 1 second. I'll pull up that. All right, give me 1 second. Tell me if you guys see my screen.
Yep, I could see it.
Okay.
So this PowerPoint, which we could actually pass on to everybody, was the PowerPoint that I made up for the techs. So like Lisa said, one thing from just talking to them, they didn't realize why we were triaging. Like there was a very big disconnect of what triage was and what their new role was. So what I first did was explain the triage process to them and the 3 most important factors of it, which I thought were really important because a lot of times they're rushing to get people on the back, or they take vital signs, they're interviewing people, and they're leaving the nurse actually out of that. So with that said, I really tried to bring home the fact that the triage nurse needs to, there are 3 components of triage the triage nurse needs to do. That is a visual assessment of the patient, that is a verbal interview with the patient, and then there's your vital signs. And with those 3 assessments, we come up with our ESI. So I basically explained what ESI was, what we're looking at in all 3 of those assessments, and what factors make someone a potential, a risk, stable, and then how we go from there. So their feedback is that they really like that aspect of it. They have a better understanding of what we're doing. So that was the main part of it. And then the other part was their new roles, which is also a new role for us. So the screener, the triage tech, and the triage nurse. And the 3 of us being somewhat of a team, or definitely a team outside. So the screener is a new role within the hospital, and I don't know if everyone actually knows the purpose of the why behind the screener became. So the purpose of this screener is to always be at that door. Why? Because it's locked, and there always needs to be an eye on the door to allow people in, to get that quick assessment. Are you here for a stroke, a heart attack, COVID, flu? That is the main purpose of the screener. So if we are at a full staffing complement, the screener should just be at that door at all times. We don't want people standing in that little area, banging on the door if they're having a heart attack, you know, they have to be seen right away, or if there's a major illness or whatever. There shouldn't be a delay in that. So the purpose of the screener is to greet and make sure, you know, open the door, greet them, and acknowledge the patient. The next part of the screener's job description is basically they're the ED, air traffic control person. So they're going to be, we don't want people waiting outside in the freezing cold. We don't want 5 or 6 people standing on line. So what we want to do is get them parelled, masked, and into a seat right away. We want their family or whoever's with them to see security. So then the screener should separate within 6 feet all of the patients throughout the emergency room. They should basically in their head know who is first, second, third, fourth, fifth, and so on. And then cleaning up the seating areas and things like that. That is the purpose of the screener. Any questions on that? I don't think everyone knew that was their actual job. Okay, so that is what the screener is supposed to do. And then, oh, I'll review it. Okay, so they're supposed to greet the patients, seat them, make sure they have a mask, ask them the questions, and place them in the appropriate place. And then there are also crowd control. A lot of the feedback from the techs was they didn't know that was the reason and the purpose behind the screener job. And they feel that when, like, they don't understand everyone's expectations. So if I'm there one day and Stephanie's there one day and Sam's there one day, everyone does it a little differently. So I try to explain that, this is our guidelines. This is what we should be doing. You have to be somewhat flexible because outside in triage, things are consistently changing. And communicating and teamwork are the main aspects of this area of the hospital. Next, you have your triage tech, which is the next slide. So what is their job? They're communicating with the screener. They're communicating with the triage nurse. They will walk the patient over to the triage area. If it is really busy, maybe the triage tech and the triage nurse takes the equipment and goes to all the different people, especially if people are positive for COVID. You don't want them sitting all over the emergency room. So they are taking their height, their weight, they're doing their vitals. They're banding them. They're walking the patient back to a room. They don't have to stay and do an EKG. What is important for them to do is make sure they get changed, give them a urine cup and extra urine if necessary, give them the call bell. So that is the basic part of the triage tech. Walk around the emergency room on your way back. Scope out rooms that have to be clean or not, either call housekeeping or manage it up to the triage nurse or the charge nurse so our rooms are consistently being cleaned. Then, so that is the nutshell. I know nighttime, so then we talked about the nighttime. You guys have a pretty good system. A lot of times it's just a screener. They interview the person, they start their vitals, and then they call the charge nurse. The charge nurse comes, greets the patient, gives the vitals, and you guys go in the room for the rest of the triage. I haven't heard any complaints. Everyone's pretty happy about that. We were saying this process probably goes for 10 or 11 on, and then 7 a.m. to 10 a.m., where the census is somewhat lower. The techs are more concerned when somebody is pulled from these positions, and then how do you work it? How does your workflow change? So I try to communicate with them that, you have to talk to the triage nurse, you have to talk to the charge nurse and come up with a plan, because not every day you're going to have 3 people out there, especially until all these new people are trained. So, these are suggestions. These are some things I also do. So let's say it's only you and one person. So what is their job role right now? So to me, the screener asks the questions. They could walk them into the triage box. I could start doing everything. They could come over as long as there's no other patients, band the patient and walk them back. I am willing then to front the door and get up and talk to the people if anyone else is coming in. Or I am willing to say, you stand here and I'll walk the patient back this time, so that the flow isn't interrupted and there's always someone at the door. Should they be receiving patients? Not really. I mean, I know that they want to. I know when it gets really busy, they want to divide and conquer, but when they're doing that, these people are interviewing them and they're the wrong people to get the interview. And that's where mistakes happen. So they really should work next to you. So if you have 5 people out there and they're all situated 6 feet apart, you could either bring them into the triage area or you could go to the patients, but they should be working with you as a team. Like, okay, I'm going to receive the patient now. I'm going to interview the patient now. You do the vitals, you walk them back. I will quickly now clean the equipment and I'm going to grab the next patient that's coming in. So I know everyone does it different. Does this make sense? Any complaints, any feedback?
Jen, one thing I'm going to jump in and just chime in for you. So obviously staffing is a big to-do, and I think a lot of the issues goes behind staffing. Just a quick update for you guys. We'll have, by the week of March 14th, everybody will be trained and in their positions for the techs. So that should really help with the flow process because we'll be more adequately staffed. One thing, like you had said, that everybody has their own system of doing something, but the purpose of kind of revisiting all of this is to really create a little bit more consistency, just at least for the time being, until we build like a better, flow process and everybody is kind of on, and then we could tweak it. And just staying consistent, I think, is the most important thing for everybody, so that this way, we can really trial and get them comfortable in their role.
Is there anything that you guys think works better? What's not working with the process?
One thing I know that is an issue is that screener tech being pulled. I've met with Tracy Lander and the nursing supervisors, and I met with Maureen also, and Dr. Dwyer. So the screener role should realistically be the absolute very last person to be pulled, because like Jen had mentioned earlier, the true purpose of having somebody out there is that their patients are approaching a locked door. And the last thing we want is for patients to be at a locked door thinking that the emergency department is closed, or God forbid, somebody having a massive MI in the vestibule because the door was locked and they couldn't get in. So, again, communication, the tech should be the last person pulled out there. If they are being pulled for any reason, security, is aware that they own that door and that door has to be manned at all times.
I do have a question regarding that, because on Sunday night, the tech got pulled at 11. So Thelma was out there at 11. She was going to be sent to behavioral health. And that happens a lot, especially I think with the night shift.
Yep.
You have a choice between keeping your tech that's going to help on the floor or the person out there. And, you're kind of told this is what it's going to be. So how are we escalating that up?
So again, we can't always, we can't avoid them being pulled entirely. I have messaged it, and like I said, I kind of used the channel of Dr. Dwyer as, like the blame for it, because again, the ED has needs as well as every other unit. And that resource, the screener person, again, should be the absolute last resource pulled. Obviously, if there's a one-to-one in the hospital somewhere and they need that tech, if there's a behavioral health one-to-one, you have to kind of do a cost and weight analysis on what need is higher. So we kind of, and like I said, security is aware that they own that door. So it just needs to be a proper handoff if that person's being pulled. I think it will get a little bit better. They have postings all over the place. Again, it's a staffing issue. We're trying very hard to recruit more PCAs, and once our ED staff is, adequately staffed, we should be in a better place. Because if our core staffing is, 2 at night and we have 2 of our ED techs, they really shouldn't be pulling our ED techs and pulling us down from our core.
Anything else on the process? So I just kind of want to open up the forum about the ESI. If anyone has any questions about ESI, we could clarify. Ashley spoke at the last charge nurse meeting, which I know a lot of you guys weren't at. So there's some neuro changes or updates, and it will affect all triaging. So WEMS is now Tiger texting incoming potential code strokes. So the BL will receive the notification and they should be telling the charge nurse. And then the charge nurse will be telling whoever's going to be triaging the patient, or should be telling the team or the nurse, the patient's coming in, possible code stroke. These are the vitals. These are the scores. So that is one way that we're streamlining strokes and trying to get to everyone quicker. If it is in the hours of actually working, and you're triaging a possible code stroke, vocera her so that she could start heading down to the emergency room. And then I'm pretty sure everyone has seen the BFAST assessment, which is now part of the triage process. And that assessment, if it does pop up, it's kind of like a code sepsis. You're going to broadcast potential code stroke in the emergency room, and that will, tell the team that somebody's coming in and needs attention right away. Like always, any patient with neuro symptoms that started at least 24 hours should always be a level 2. So that hasn't changed.
I'm going to jump in there too for you guys. So I think historically, we as ED nurses under triage, and we make a lot of what potentially could be T2s, we make them T3s. And whether that's because of the provider that's working that day, or, maybe we didn't get the vital signs first before we assigned it. But I will tell you guys, while you guys are doing your triages, really do a deep, thorough triage on your patients. Make sure that your vital signs are completed before you're assigning an ESI level, because when you guys assign a T3, so I've been pulling numbers for staffing reasons, right? So our volume in the ED since COVID has been significantly decreased. Obviously, we have days that are crazy, but our volume is definitely down. I know for a fact that the acuity in this department is higher than it has ever been. So the people are really sick. When I pull data to look at the ESI levels, the acuity doesn't reflect in the ESI levels, right? So when I bring back paperwork to senior leadership and I say, like, oh my God, the patients in our ER are so sick, and the time that the nurses have to spend in the room, and I can't prove that because the numbers don't match. So when you guys are triaging, really make sure that you guys are understanding the ESI level and why you're triaging it the level you're triaging it. And again, making sure that your vital signs are done prior to you assigning the triage, assigning the ESI. And again, in turn, that's going to help us get more resources that we need for what's actually happening in the department. Does that make sense? Do you have anything else you want to touch upon, Jen?
No, that's really the neuro is the biggest update with the ESI. If nobody has ESI questions or want to review anything, we could even, I have some PowerPoints up here with ESI. So if anyone needs that review or wants to talk about something, I'm happy to go through things. Do you want to pop up the 1-7 just to review the numbering? If you feel like, so an ESI 1 is someone that's requiring immediate life-saving interventions, cardiac arrest, overdose with a respiratory rate of 6 or below, major traumas, severe respiratory distress. And then we have our ESI 2, those are the high-risk situations with the potential of becoming critical. So I think right there is, if the person has the potential, we're going to look at our visual assessment, our vital signs, and our interview and decide, what's going on with the patient. Are they septic? Is this a cardiac event? Is this a stroke? Severe allergic reaction, pain, GI bleed? Are they symptomatic? So when anyone has that potential to turn into a critical, at that moment, you should upgrade them to a 2.
Sorry.
So if you have the COVID patient that walks in and their oxygen is 88 and they're gasping for air and they physically look like shit, you should probably just, it's recording. If they physically don't look well, you should make them a 2. Or if you have that sepsis patient, or if you have a cardiac patient, I was just at the cath lab last week and now I'm having the same chest pain again, and the person's diaphoretic and the patient's vital signs show it, upgraded to a 2. We keep them as a 3 when they're basically the patient is stable. So we know that this person's stable. We know that they could, we don't have to rush into the room right now. And we know that they're going to need 2 or more resources. So the COVID patient that says, I came in, the doctor sent me over because I have a low oxygen, but I feel okay, whose oxygen is a 94, 95, but all the other vital signs are fine, heart rate's fine, blood pressure, they don't have a fever, they're not complaining, they could be a 3.
One thing I think we forget, so like, again, the snowstorm, right? We had a lot of patients coming in with amputations, right? So their whole fingertip was cut off. Those should be T2s, just to make sure, because those patients are most likely going to go to the OR to have some type of intervention, whether it's a flap or whatever. So those patients should really be T2s. And that's just like little things, those are the little ones that we kind of just missed, that you're thinking like, oh, he cut his finger, like, let's just, but really as the triage nurse, we should really take a peek at it, look at it, see what it looks like. How much is it actually bleeding rather than just wrapped in a cloth. So just those little tiny things that we need to do as triage nurses to really appropriately triage our patients. One thing while I have you guys here, I'll give you, so what we're doing, I sent it out in an email with the behavioral health stuff. We're working with Northwell to align again with the Northwell policy. And we are creating a triage assessment for the behavioral health patients. So it'll be linked to the behavioral health chief complaints. And what it's going to be, it looks cumbersome, but it's really not. It's called the Australian Mental Health Triage. And what it does is it asks a lot of suicide ideation questions. What it does after the triage is it grades the patient to a behavioral health level. So, right, so we have ESI levels, we will now have a BH level. And it's not something that's going to pop up on the tracker or anything like that. It is information that the physicians do need to know because that's information that they need to reiterate to telepsych. So what it is kind of very similar to ESI. So anything with a level 1 or 2 would be considered like the higher acuity. Those patients are your patients that are, actively suicidal, who are going to be on COs. Anything 3 and under is a CO. And then when you look at it, the ones that are grading like a BH of 4 or a 5, it's really, a nursing assessment. We might put them on a CO quickly, and then those can quickly de-escalate to an enhanced supervision. Or somebody's coming in with, anxiety. I've been having a lot of panic attacks. They may be a BH level of 4 or 5 and could go to room 23. And doesn't need to be wanded and, undressed and all of that good stuff. So the tool is there to kind of help take the guessing out of what we already do. We're looking to kind of roll that out probably in March. I'm just waiting for Meditech to build it properly so that it works to its full functionality. Does anybody have anything about the triage process, the screening process? A lot of you are charge nurses, so what are you guys, any concerns or issues that you'd like to address to bring forward so that we can discuss it with the triage small group? All right. Jen, do you have anything else for triage?
No. And anyone has questions after the fact, approach me, email me, text me, whatever you like. Happy to answer it.
Great. I'm going to stop recording. Hang on.